Hi, I'm Robert Mark, and this is the Robert Mark Show. Thanks for joining me on another afternoon, if you're on the East Coast, another morning, if you're on the West Coast, of our wonderful time together here. We're in countdown to Barack Obama's presidency, and with it brings lots of promise. We hear in education, with our economic situation, and hopefully with our health care situation here in the U.S. And of course, it's been an ongoing discussion on my show about various issues affecting our community. And I think none more important than the topic I have on today, to discuss today. I have Dr. John Lipman. He's a pioneer in the development of uterine fibroid embolization. He's also director at the Windy Hill Hospital in Marietta, Georgia. Author of several published articles, has appeared live on CNN and interviewed with USA Today and the Wall Street Journal. Why are you here, Dr. Lipman? Because we're not USA Today. I'm joking with you. It's great to have you on the show.
It's great to be here, and I really appreciate the opportunity. As you know, this is a very important issue for the African-American community and African-American women in particular, but it does. Obviously, anything that affects African-American women are going to affect men as well. So it is a big issue, as you know. Well,
let's talk about the exact issue because, again, healthcare is a very important topic on this show. And let's talk about the exact health care issue we're discussing.
Well, we're talking today about uterine fibroids. And fibroids are benign, non-cancerous tumors that grow in the uterus. And they affect probably up to 80% of African-American women of childbearing age. So it's very, very prevalent in the African-American community. Now, even though these tumors are benign, their symptoms can be very disabling, namely the very heavy bleeding a woman gets each month with her menstrual period, very heavy bleeding, heavy periods, often leading to anemia. They get significant pelvic pain, and they get increased urinary frequency, and it's the leading cause of hysterectomy in this country, even though these tumors are benign. So uterine fibroid embolization is a procedure that is completely non-surgical and can replace the need for pretty major surgery. So it's a huge breakthrough for women, particularly African-American women who disproportionately suffer with fibroids.
And so, looking at fibroids, what exactly causes this within women?
Well, nobody knows exactly how fibroids begin. They're made of very firm, fibrous, and smooth muscle. They're very hard and firm tumors. Nobody knows exactly how they're formed. Now, they do respond to estrogen and progesterone, so that's why they will grow during a woman's pregnancy, and why they're not an issue for women in menopause. Mm-hmm. So typically, women that are affected by this, they may find out about their fibroids, say, in their 20s or perhaps 30s, but they're usually not an issue for a woman clinically, medically, until well into their 30s or maybe into their early 40s.
Yeah. Let's break there for a second. When we come back, I want to talk to you about your background in this area, how you got into it, and why you're so passionate about this issue. And we're back in a few minutes.
Ready to go right into the next one then? Do you need me to hold up the 60 in 30 seconds? Yeah? Okay.
And we're back on the Robert Mark Show with Dr. John Lipman, and we're discussing a very serious topic here, but one that appears as hope. A lot of hope here. We're talking about uterine fibroids, and I guess work being done to create a less impacting situation for those who suffer and those who need treatment. And your background is quite extensive here, looking at what you've done. What actually made you really dive into this issue in particular?
Well, I've always been interested in women's health. I trained, I did my radiology training at Brigham and Women's Hospital, and was exposed to a lot of women's health at that time, and then went on and did my interventional fellowship at Yale, and it was a big center for women's health, and so I've always been interested in women's health, and my practice currently, and I've been practicing for almost 20 years, has been women's interventional procedures, doing procedures that replace the need to do something surgically. So instead of an open surgical procedure, you could treat the same condition from the inside. So in this particular case, instead of doing hysterectomy and doing a surgical removal of the uterus, we can treat the symptoms from the fibroids completely on the inside. So a woman that sees me does not need to have hysterectomy. She can come in, we can do this uterine fibroid procedure. It's done as an outpatient. The patient goes home the same day with a Band-Aid, so there's no surgery, no stitches, no surgical incision or the surgical risks that go with it. She goes home and recovers typically on average 4 days, and by a week she's back at work, versus the surgical patient that is in the hospital 4 or 5 days and then has about a 6 to 8 week recovery at home. And my patients get to keep their uterus.
That's a very, it's like night and day.
It really is.
It's like night and day, and I'm wondering again, the passion that I hear in your voice about this, it almost seems somewhat, it's amazing that this process is available and it's out there, and I'm sure there's been a lot of background, a lot of work that's gone into this development, correct?
It has, and it's been available for 13 years. I'll see women every day in my practice that say, I've just never heard of this before, and is this something new? Is it experimental? Mm-hmm. Is it investigational? No, we have long-term proven data in the medical literature, in the gynecology literature. It's a procedure that has been proven safe and effective over many, many years, but still, unfortunately, many women have not heard about it, and that's unfortunate. I mean, Condoleezza Rice, for instance, she had the procedure back in November of 2004. She had it on a Friday morning. She was back to work Monday morning. It just points out how quickly women can recover. It also points out how certain people can have information and access to health care and others do not. I mean, and that's why it's so important. I mean, I've teamed up with Beverly Johnson, the supermodel, and she was suffering with fibroids. And unfortunately, she never heard about the embolization procedure and ended up having hysterectomy and some issues afterwards. But she's taken a negative thing and turned it into a very strong positive thing by educating women that you have choices, you have options. You no longer have to have hysterectomy if you're suffering with fibroids. Now, if you have cancer, certainly, cancer, there's no discussion. Hysterectomy is appropriate. But for fibroids, you have excellent non-surgical options.
And so again, the question here is, with all the research done, well, for listeners out there who can't, like myself, understand how something that sounds like the best possible scenario is still so quiet. What goes into creating, developing a new process, and what stakeholders have to actually be on board to make this type of new process more popular, more accepted, et cetera?
Well, I think there are a couple of issues here. One is the stakeholders, as you say, are gynecologists.
Okay.
Typically, women that suffer with fibroids will go to their gynecologist, and oftentimes the gynecologist is the gatekeeper of a woman's health. She'll often see a gynecologist for everything related to her health. And so she relies on the gynecologist to recommend whatever treatment plan, depending on what the issue is. Now, in this case, it's fibroids, so she would be suffering with fibroid symptoms like I talked about earlier, bleeding, pain, urinary frequency, what have you, would go to the gynecologist. They would discover, typically on physical exam, that her uterus is enlarged, and they do an ultrasound in their office and see that she had fibroids and say, okay, you have fibroids. Are you interested in having children or not? If not, they would recommend hysterectomy. If they were, then you could have surgery to try to cut out some of these fibroids and sew the uterus back together. But a lot of times women are only hearing about those surgical options. They're not hearing about uterine fibroid embolization, the non-surgical option.
Now you mentioned symptoms, and I think, again, it's a good chance for us to discuss two things. Symptoms that tell a woman, when they may want to have dialogue with their doctor.
Yep.
And the second piece I want to ask you about is the after effects of having hysterectomy. What are some of the things that happen after they have one?
Well, the symptoms, fibroids, as mentioned earlier, are hard and firm. They're like rocks. And so they will cause symptoms based on where they're located in the uterus. So fibroids that are located in the center of the uterus, near the lining of the uterus, will stretch that lining and cause very heavy, gushing, flooding periods. Women will change pads very frequently, sometimes every hour or even less. They will, gush and flood blood will just gush out of them. It can be very disabling. They can, if the fibroids are in the muscular part of the uterus, they can press on things to cause pelvic pain. If they're near the bladder, they can press on the bladder to cause this increased urinary frequency, waking up in the middle of the night number of times or going more often during the day. Again, very disabling symptoms. And so those are the symptoms that are typically associated with fibroids, and then they're proven based on physical exam. A woman's uterus may be described as a certain size pregnancy because the fibroids will enlarge the uterus. And it's something that they can see very easily in the office on office ultrasound.
So then, as far as when to discuss such issues with your doctor, would you say that once you have these symptoms, you should go immediately to your doctor?
Yeah, once you have those symptoms, because just having fibroids, as I said, probably up to 80% of African American women of childbearing age have fibroids. And if you have no symptoms, you don't need to do anything about it. You need to know that you have fibroids and just continue to follow up with your gynecologist. So no symptoms, no treatment. But if you have the symptoms that we just described, then it is important to first dialogue with your gynecologist, listen to what they recommend, and if you're interested in uterine fibroid embolization, this UFE procedure, discuss it with your gynecologist, but also you'll have to discuss that with an interventional radiologist.
Gotcha.
It is those kinds of physicians, interventional radiologists, that do the fibroid embolization procedure. So you would need to get a second opinion, if you will. A number of gynecologists will...
Let's hold it right there for a second. When we come back, we'll talk more about this and the effects of having hysterectomy. And we're back shortly. And we're back with Dr. John Lipman. And wow, the schools you have either lectured at or attended are Georgetown University, Stanford, Harvard, Vanderbilt. You've been all over the place, huh?
I have.
Yes.
I've lectured numerous times, not only to physicians, but also the lay public as well. I'm trying to educate gynecologists on making sure that they discuss all the options, not only just the surgical ones. They discuss this option with patients, and also to lay groups, how important it is for women, whatever the situation is, to empower them with information. In this particular case, it's fibroids, but we all need to take more responsibility for our health.
My father had cancer, and this is a sidebar here, and he went through radiation or chemotherapy, right? And to the layperson, it looked as though prior to chemo, he was in much better health than he was as he took chemo. This is a layman's observation, okay? And we never thought about the after effects of treatment, okay? We thought about what the treatment could do to help a person, but not what the effects can be on a person. So with that type of situation, with taking it to our situation with fibroid treatment, what are some of the after effects that women should be aware of when they agree to do the other procedures?
Well, I that's a great question, because when I talk in talking to a number of gynecologists, they'll often say, well, if a woman's not interested in having children, she should just have a hysterectomy. And I think that's assuming that the uterus is only good for childbearing, and I think that's a very myopic and naive thing to say or to assume. Just like with women's heart disease, for many years we thought, if women got heart disease, it would be just like men. It was kind of chauvinistic. Mm-hmm. We never studied it. Mm-hmm. When we actually sat down and studied, it was clearly different. Mm-hmm. And it's the same here. I mean, the uterus is not just for childbearing. It's not just an incubator, mm-hmm. and then when they're done with it, just throw it in the pan. Mm-hmm. It does have other functions. In mm-hmm. fact, a very interesting study was done recently. They studied women for 20 years from the same area in Europe, and they started in their 40s, and they studied them for 20 years till they were in their 60s, and the only difference between the group was one had hysterectomy and one did not, and the group that had hysterectomy had a much higher incidence of heart disease and coronary artery disease and heart attack and death than the other group. And as it turns out, they were floored by this result because they couldn't figure out the connection, but it appears that the uterus produces a chemical called prostacyclin, which is a powerful vasodilator. And without that vasodilator, you're kind of left in this relative vasoconstrictive state, which they believe led to all these coronary events and heart attack and heart disease in this other group. So we shouldn't be just so cavalier and just take a woman's uterus out, particularly when we're talking about a benign condition. Mm-hmm. Again, fibroids are benign. They're not cancer. So the uterine fibroid procedure that I do, the fibroid embolization procedure, I think it's really the biggest breakthrough for women, particularly African-American women, that's maybe ever been. I mean, it's a tremendous procedure that relatively few know about.
And so, going with the more traditional type of surgery you mentioned earlier, the hysterectomy, are there certain common side effects that women experience?
There is. Mm-hmm. After hysterectomy, you can talk to women that have had hysterectomy, mm-hmm. and there are a number of issues afterwards. There are psychological issues about feeling less of a woman, just like a man who has been castrated. Mm-hmm. You can talk about sexual issues after hysterectomy. There are a number of women that they're not interested in sex anymore, mm-hmm. or sex is not as enjoyable anymore. There's a lot of sexual side effects. There are urinary side effects after hysterectomy. After you remove surgically this big uterus full of fibroids, and now you've weakened the pelvic floor, a woman has difficulty controlling her urine. Mm-hmm. So there are urinary issues after hysterectomy. There are the surgical issues of, complications during surgery or after surgery. And most abdominal procedures will get some sort of adhesions just by opening a woman up, and these adhesions could lead to bowel obstructions or other problems. So whenever you don't have to open up somebody's belly, I think it's a good thing.
Well, hold those thoughts. We'll come back with more on this very timely and serious issue. And we're back. Robert Mark here, and having a great conversation with Dr. John Lipman. And our show is is a national, reaches all the states, you might say. And so do you find that there's a certain region around the country that suffers more from uterine fibroids, or that is more proactive in seeking treatment?
There are certain, just like there is an ethnic predominance in African American women, you'll see regional differences. So certain areas of the country that are higher in African American populations will have higher fibroids and also higher hysterectomy rates, because that is the leading cause of hysterectomy. So we have the highest hysterectomy rate, the southeastern United States. I'm in Atlanta, and the southeastern United States has the highest regional hysterectomy rate. So I think some of it is education and or the lack of education, and lack of getting kind of the word out on some of these newer, less invasive techniques, and some of it is just based on population.
Do you find that in certain regions, culturally, within our community, African Americans, do you find that in certain regions there's less of a sharing information? Do you find that folks talk less about these issues? They're more quiet, they're more hush-hush?
I must say that I did find that, and it was only after conversations with Beverly Johnson and some other prominent African American women that I've met and worked with and had the pleasure of doing conferences with that I really got to some of that. I didn't really understand or didn't even know about that issue. She was telling me that that it's a very difficult conversation, and oftentimes she feels that it's a cultural thing that African American women aren't discussing fibroids mother-daughter, not having that discussion. And that's so important, because I see a number of patients in the office that when we talk about fibroid embolization, the mother may tell the daughter, well, just have hysterectomy. That's what I had. And really that is it's an impediment, I think. They're not getting the best information, and that, yes, it may be the only thing we had when Mom was suffering with fibroids, but we've really come a long way. And I think as people start talking about it and talking about hysterectomy openly and talking about the alternatives openly, they'll see how this is, say, a godsend. It's one of the biggest breakthroughs for women, and it's been a tremendous procedure that women have been able to avoid major surgery, and kept their uterus. So we need to. She's been outspoken on encouraging the dialogue. Friends talking to each other, moms talking to daughters, and so forth. She has a daughter in her 20s, and she's already had the fibroid talk, if you will, and she wants to tell every woman that it's too late for Beverly. She's had a hysterectomy and had some issues afterwards with it, but she wants to empower women with information that you have choices.
Now, during the election, we had two very different approach to healthcare. We had one issue discussing more about independent choice. We had another one talking more about healthcare for all. But ultimately, I think a dialogue about information, being informed, making the right choice, whichever system we move with. Do you find that it's important for patients to research on their own and learn more about what's out there and not rely upon their primary doctor or physician to give them the information? Very
much so. I mean, back in the day, if you will, it was more paternalistic. The doctor would tell the patient, "You need to do this, period, end," and that's just not how we practice medicine anymore. I mean, I know myself that it's very difficult to keep up with all the latest things in every aspect of medicine. So you really do need I partner with patients to take care of them. We work together to try to find the best solutions for them. I will outline both surgical and non-surgical approaches, and we will decide together. The patient will make the ultimate decision, but we will give them different, choices. And it's important that a patient doesn't just show up to their doctor's office, that they research themselves, they go on the internet. Not that the internet is gospel, but there's lots of important information you can find on the internet at reliable sources, and then take that information, use it, read about whatever you're suffering with, and then arm yourself with questions that you go to your doctor's office and you're prepared. You ask questions. You're not just sitting there like a child waiting for the father or the mother to tell you what to do.
Mm-hmm.
You're taking an active role in your health. You're researching it. You've got questions,
Mm-hmm.
and it makes that visit much more important and much more the outcome. You'll be much better off for that. Your doctor will appreciate that you've taken the time and effort to look into these things and go over it. It's a much better consultation and exam.
Well, again, our healthcare system, is one that many would say, or some would say, it could be somewhat classist, based on access, based on resources, etc.
Yes.
And I think it's fair to say that in every industry, you have folks who really care, and folks who may not care as much. I think whether it's civil service or private industry, you have that culture, and so the question here is, when you walk into the office of a doctor, and you are informed and you do understand your choices, does it make that doctor respect you more as a patient?
I think it does, and it also, you can then, because it's impossible to know which doctors I think are motivated by helping you, which doctors may be motivated by other things, mm-hmm. economic or other reasons. And if you're armed with information and you're just not liking the answers that you're getting back from your doctor, mm-hmm. You go to another doctor. Mm-hmm. If you go to a doctor and you're armed with stuff and you're working together and you can really feel a connection, yes, this doctor is really working with me. We're a partner in our health, and I I feel good about that. Then I think that's an important relationship. But mm-hmm. It's hard to know what people are motivated by, and I think the more the patient is engaged, the more that they can make a good decision about who's taking care of them or who's working on their healthcare team with them.
And so, again, that was the basis of my statement was, it sounds as though with your procedure that unless the patient really, at this stage at least, really pushes the issue and seeks the information and becomes an advocate for themselves, that yep. they may not receive what they need to make a much more informed decision.
Unfortunately, there's some truth to that. Now, I must mm-hmm. say that in my particular practice, most of the patients I see still come from gynecology referrals.
Okay.
But in many instances, it's not the case that somebody has to hear about it themselves or really have to take an active role and find out about this. And so there's both. But irrespective of that, I think it's always important mm-hmm. for the patient to arm themselves with information, empower themselves with information. It's always a good thing.
Yeah.
You can never have too much information about your health, and I think it's always good. And then, you decide. But to actually see about UFE, you'd have to see an interventional radiologist. So okay. You'd see, two physicians, but that's okay.
Now, when we come back, I want to talk to you about diet and preventive medicine, what we can do to help ourselves avoid having to deal with some of these health issues. And
okay.
We're back shortly. And we're back. Robert Marks here, speaking with Dr. John Lipman. And wow, this information's amazing. I have sisters and cousins, and when we're done talking today, I'm going to get on that phone and make sure I call. And also, I challenge my listeners to also call and start having more dialogue about these issues, because only through conversation can we have a clear resolution and change here. But I was thinking about education and how parents push their kids towards preschool and kindergarten and all that, and expect the teacher to educate the child and become that primary provider of information. And I'm wondering about diet only because quite often we think of a doctor as solving our illness and not always providing consultation on how to keep from getting ill. And so in hearing about the uterine fibroids, what can women do to prevent this, or to help themselves, or to not be victims in the process?
Well, for African American women, there is a strong genetic component. So, unfortunately, at this time, until we can develop and get to the vaccine level to try to identify families with strong histories of fibroids and someday give them a vaccine, at this point, a lot of it's genetic, and therefore, in those individuals, there's not a whole lot they can do other than just eating well, having a low body fat. As I mentioned earlier, fibroids grow with estrogen stimulation, and estrogen is stored in fat, and so the more fat you have on you, the more fibroids will be stimulated and tend to be bigger, and more likely you'd have symptoms that in the past often meant hysterectomy. So if you can keep as lean a body frame on you as possible, that's certainly something that everybody can do. Now, as I say, I commonly will see African American women in my practice with a very low body fat and very big fibroids. And in those people, they're doing what they can. It's just genetic. There's nothing, they can do about it. But for the rest of us, we can always try to eat as good as we can and keep a low body fat. It's obviously good for your heart and heart health. It's good to prevent secondary diabetes, and it also helps with fibroids. It's just one more reason to try to exercise and be as lean as possible.
Now, are there connections between fibroids and other illnesses that, based on diet, you mentioned earlier diabetes and such, but is there a connection between fibroids and other illnesses that come from the same lifestyle or the same gene pool, so to speak?
Well, there is some connection with fibroids and thyroid diseases, thyroid nodules, but I'm not aware there's any connection with diet. There's been, unfortunately, precious little research done on fibroids. Because they're benign, they really don't they're not high on the list for the NIH and some of the major, research houses, if you will, in the United States. The NIH has only recently convened just to even study fibroids. There's been very little research. Most of the research goes to cancer and AIDS and so forth. And so we do know it's genetic. We know the chromosome that's involved, but we have to get to the gene level before we really start understanding fibroids and how diet impacts it, and how we can kind of do more on the preventive side, which is, really lacking.
Yeah. And so you talked earlier about the lack of research at this point and such. Is there any connection to the fact that this is predominantly a woman illness, a female illness, and also one that targets a particular ethnic group? Is that a reason for less interest or less research?
Well, certainly it targets African American women both genetically and also because in general they have more body fat on them than Latino women, who have more than Caucasian, who have more than Asian. And that's the distribution of fibroids, African American women having the most and Asian women having the least.
Right.
And as far as, access to, some of these less invasive techniques and maybe some of the knowledge about these procedures like fibroid embolization, I think there is some truth to the, disparity in healthcare. We've certainly seen it in high blood pressure and hypertension and cancer. It wouldn't be a stretch to think that there is a disparity when it comes to hysterectomy versus some of these less invasive techniques. And so we do need to educate women so that they know of their choices and know of their options, so that there will be less disparity. And but we even see, like I say, Beverly Johnson, who has means and certainly has access that as good as anyone's. She didn't get the information either. So the information is lacking for everyone.
Yeah. And so, again, the idea that that folks have to use their own means to maybe become more educated on their options is a good one.
I think it's the biggest. That's the key of this whole discussion, is that women need to be empowered with information. no matter what they're dealing with in their health. Today it's fibroids, and knowing that they don't have to have surgery for fibroids. They don't need hysterectomy. They can have fibroid embolization and these non-surgical approaches. That's very important. But as a general point, just whenever you're suffering with anything from a medical standpoint, it's important to take the initiative and empower yourself with information and make the best choice, because you're going to be much more ahead of the game knowing your options rather than kind of walking blindly into a doctor's office and just seeing what your options are.
Now, I want to talk to you about some of your upcoming any informational sessions, any special events happening to spread the word. But first, one of my listeners actually emailed me, wanted to know to tell them what is a myomectomy.
Myomectomy.
Yes.
A myomectomy is surgically removing a collection of fibroids and sewing the uterus back together. Before we had fibroid embolization procedure, a woman really only had two options. They were both surgical, and a woman suffering with fibroids would go to her gynecologist, and the gynecologist would say, do you want to have children or not? If she wanted to have children, she would get a myomectomy, if not a hysterectomy. But now we have fibroid embolization, and women can avoid surgery altogether.
Gotcha. Well, we'll come back and hear about some of the events coming up that may be able to provide women with more information, and we're back in a second. And we're back. Robert Mark here with Dr. John Lipman, and we're talking about a very, very critical issue, uterine fibroids and treatment options that will provide relief, really, for many women. You mentioned Beverly Johnson being an advocate for your this procedure we're discussing. Are there any events happening, any online events, any live staged events happening around the country that women can tap into to learn more about this procedure?
There are events. Her site is ask4tell4.com. It's ask4tell4.com, and they will often have a series of events. You can look at Beverly's story, and they also talk about different options, and they have events, throughout the year. Also, my website, which is www.atlii.com. It's short for Atlanta Interventional Institute, ATLII. We will have seminars and throughout the year. I speak all over the country, and so we'll often have events posted where I'll be speaking or others will be speaking on this.
Now, you mentioned also that you travel to various universities and provide lectures to physicians. What's the feedback there within your own community?
Oh, I think it's very positive. Obstetricians and gynecologists went into that field to help women, and say most of the patients I see come from gynecology referral. So they've seen the power of this procedure, and so it's educational, providing them. They have to be comfortable with the procedure. They have to be comfortable with referring to an interventional radiologist that has the skills and expertise. But the procedure is an excellent one, and they've seen that. And so I think that it is receptive, and we continue to educate them, and we continue to talk to the public and educating the public. And so, through programs like yours and others, we're getting the word out. So it's coming along.
And so in contrast, when you present to the public and communities, is it shock, surprise? Is it proactive dialogue? Was it more of a reserved conversation?
Well, it's a different conversation. There's certainly a lot of people that do have they're surprised in the fact that it's such a minimally invasive procedure. Say it's done as an outpatient. They go home the same day with a Band-Aid.
Mm-hmm.
It sounds too good to be true,
Exactly.
but it is outstanding.
Right.
And so there is, more kind of they're really surprised how simple it seems and how easy. And we encourage patients to talk to prospective patients, talking to people who have had the procedure, because it is tremendous. It's a huge breakthrough, and so the conversation is spirited and much more. They're like, wow, and I show. We have before and after pictures. We have
Wow.
the comments from patients. I mean, patients often will tell me I've given them their life back.
Wow.
I mean,
Wow.
when somebody has been tied to their menstrual period, they can't work a couple days of the month because of their gushing and flooding, and they're afraid of losing their job, and they're at home. So it affects their work life. It affects their home life. They don't feel sexual. They're flooding and gushing, and they're anemic. They're tired. They can't exercise. They're just physically wore out. And then they go to very light, normal periods, and they get their energy back, and it gives them their life back. They're no longer tied to what time of the month it is. It gives them their life back, and they're just so appreciative. It keeps me coming to work every day. It's tremendous.
Well, I thank you so much for your time this hour. It's been very informative, and I want to invite you back to discuss.
I would love to. I really appreciate it.
Yeah, and women have actually called me and emailed and want to know more about this process. So I won't pass out your number, but I'm sure you'll get some feedback on your website and ask Beverly. Okay?
Great. Well, thanks again, Robert. Every time we talk, we touch more people that we will never meet.
Yeah. Well, thanks again. Have a great afternoon, and that's it. I'm Robert Mark.
Thanks.
I'll talk to you next week.